Neonates admitted to the neonatal intensive care unit experience an average of 10 painful procedures per day as part of routine care. Pain management in neonates is challenging due to the neurotoxic risks of both untreated pain and the commonly used analgesics like opioids, particularly concerning for preterm neonates and those with hypoxic ischemic encephalopathy who are already at higher risk for poor neurodevelopmental outcomes. Although effective pain control is essential, overuse of analgesia can lead to unintended consequences, including delayed feeding and impaired brain development. Unfortunately, guidelines for pain management in neonates are incomplete and outdated, leading to inconsistencies in clinical practice. One key challenge is the lack of consensus on how to categorize neonatal procedures by pain severity, which contributes to inadequate pain prevention for many procedures, including lumbar punctures. Lumbar puncture is a moderately painful and invasive diagnostic procedure, usually performed to work up an infant for bacterial meningitis. It requires an uncomfortable curled-up positioning and involves needle insertion into the lower spine. Without proper analgesia, neonates exhibit significant stress responses, which may alter cerebrospinal fluid dynamics and affect its diagnostic value. In this video, I'll outline a framework for the preemptive management of pain associated with lumbar punctures, one of the most common painful procedures in infants. In order to adequately prevent pain, systemic and local pharmacologic agents should be used concurrently, given about 45 minutes before the procedure. For systemic analgesia, I recommend either fentanyl or dexmedetomidine. Fentanyl provides rapid, potent analgesia with a shorter duration of action and fewer cardiovascular side effects than morphine, making it a better option for brief, painful interventions like lumbar puncture when an opioid is preferred. Fentanyl may be given at a dose of 0.5 to 3 micrograms per kilogram intravenously. Alternatively, dexmedetomidine at a dose of 0.2 to 2 micrograms per kilogram intravenously can be used. Unlike morphine and fentanyl, dexmedetomidine does not significantly affect respiratory drive or gastrointestinal motility. Dexmedetomidine is an alpha-2 adrenoreceptor agonist with analgesic, sedative, and neuroprotective properties, and should be strongly considered for this indication as an opioid alternative. Of note, we only have data for dexmedetomidine for procedural pain prevention in infants and children outside the ICU. These data show dexmedetomidine has similar sedation and anxiolysis, with less postoperative agitation compared to midazolam, and more sedation versus diazepam. There is a lot of variability in dosing, especially by age and route, per limited literature. I recommend 1 microgram per kilogram intravenously for procedural pain management, 45 minutes before lumbar puncture. Importantly, dexmedetomidine can be administered buccally using the undiluted 100 microgram per ml intravenous formulation if the neonate does not have IV access. Lidocaine 1% preservative-free injection should be adjunctively administered prior to lumbar puncture, infiltrated around the target area to a maximum volume of 0.8 milliliters. Topical Emla cream may convey additional benefit when used adjunctively. Emla cream is a topical anesthetic containing 2.5% lidocaine and 2.5% prilocaine and is only effective as an adjunct. Apply topically 45 minutes before the procedure for optimal effect. Historically, concerns have been raised about Emla's potential to increase methemoglobin levels, particularly when used in large doses. However, studies have shown that doses up to 1 gram, which is 1/5 of a tube, are safe and do not significantly affect methemoglobin levels in term infants. Oral sucrose, used for mildly painful procedures, has no benefit and is not appropriate for this indication. Of note, non-pharmacologic techniques should be used in conjunction with pharmacologic therapy to improve comfort. One of the most effective strategies is swaddling, which decreases the initial pain response and helps preterm neonates recover more quickly from painful procedures. Other effective non-pharmacologic approaches include skin-to-skin contact or kangaroo care, non-nutritive sucking, human milk, and music therapy. While the optimal combination of non-pharmacologic interventions is still unknown, integrating these strategies into routine neonatal care reduces behavioral pain responses and enhances overall pain management. By incorporating these evidence-based pain management strategies, you can minimize stress and discomfort in neonates during lumbar puncture. Thanks for watching. All my references can be found in the video description. Please let me know in the comments what topic you'd like me to cover next.